I have one thing, but is my voice get bigger? It's already a thing. Oh my word.
Do you want me to start talking?
Yeah.
Okay, great. So, hi everyone. This is the first CME brought together by the Intermed Pediatric Specialists Collaborative Work Group and Maine Medical Partners Pediatric Specialists. Both groups' goals in coming together are to enhance patient care first and foremost, as well as to facilitate communication and education between the pediatric providers at Intermed and the pediatric specialists in the community. And so I wanted to introduce Dr. Stanley SChaleff. He's hematologist oncologist with Maine Children's Cancer Program and the head of quality initiatives at Maine Medical Partners Specialty Care. And today he's going to be presenting on pediatric anemia referral guidelines. So welcome, Stanley. Dr. SChaleff.
Everyone can just call me Stanley. Before I start, are there any questions or thoughts? And I want to give a little background as to why I know from your standpoint why you're doing this, but from our standpoint, I guess I'll start there. We've realized that patients, we really want to facilitate the communication that we have between us and the primary care providers just to enhance the patient education and experience. And in this setting, we also feel that there are certain things that are very appropriate to be coming to us and certain things that could certainly be managed by the primary care physicians, and we'd like to try to empower the primary care physicians to do as much as they can, but also understand that we're always available and we're definitely there as a safety net or for any questions. So I started off by putting up this slide about how to contact us, and we've had a lot of debates on the best way to contact us, but in the end, the best way by far is by phone. So there's one phone number that 24 hours a day essentially you can get hold of a pediatric oncologist. During the daytime and office hours, you will get the front office staff and they will get back to us. Again, I want you guys to feel free to call. We also know that the providers at Intermed are some of the best in the state, and I hope that we remain very responsive because usually when you guys are calling, it really is an issue that we need to address pretty quickly. All right, so if we can go on to the actual pathway. The other thing that I wanted to do is at the end of this, if people have cases or some patients they want to present, specifically with anemia, but not necessarily exclusive to anemia, I'll certainly be happy to answer any questions. And if there's questions along the way, please let me know. And I know we do go to meetings all the time, and this is a similar platform. Sometimes it can be hard to get it known that you have a question, but just please feel free to interrupt me. So we start off with an anemia pathway for new patients to Maine Children's Cancer Program. Again, this is not for patients that are established. We usually have a slightly different model in that once they've been established with a clear-cut diagnosis, we do a lot of active management and then often get things back to the primary care once the active management's done. But so this is for new patients. Okay. So Erin has done a lot of work as well as just the quality group here at Intermed, and we've worked on this, and she sort of did the final iteration. And so this is what we wanted the pathway to look like. And the pathway, in terms of a handout, it will be 2 pages. It's oriented a little differently on the sheet. But so really, first to start off with hemoglobins under 5, hemoglobins under 7, and then age-appropriate management based on MCV. This is a very crowded slide, so I'm going to break this slide back up into its sort of easier to digest. So patients with a hemoglobin under 5 or anemia with jaundice, basically a patient goes straight to the emergency room and or call MCCP as soon as possible. So often these patients may have some hemodynamic instability, especially if it gets much lower than 5. And then the lower the hemoglobin, the more likely it is to be associated with badness. However, the lowest hemoglobin I've ever seen is in a patient with iron deficiency anemia who had a hemoglobin of 1.7. I still don't understand how that's compatible with life, but kid was up and kind of running around as a 3-year-old. Hemoglobin under 7, again, any sign of the following: jaundice. And jaundice in general is something that will certainly get us kind of anxious, especially if we're worried about a hemolytic process. Any other cell lines down, also indicative that there might be other problems. Something obviously, if the pathologist calls you about blasts, and I have no doubt you're calling us right away. Or if the patient has hemodynamic instability. You know, a 14-year-old with a hemoglobin of, 6.5 is probably not as stable as a 3-year-old with the same hemoglobin. Also, it gives us some indication of how quickly this occurred. And of course, hemoglobins that drop rapidly are far more likely to cause hemodynamic instability. So for patients in this category, again, we want the paradigm to be that you call us, and then the patient will likely go to the emergency room or main medical center emergency room. And the same, to some extent, goes for the hemoglobin under 5. Okay. And so the approach, there's multiple approaches that we can use to look at anemia and how to make the diagnosis of which type of anemia it is. The most common, I think the most durable, is the one using MCV. As all of us who know, taking care of children, normatives are somewhat based on age, and that's the case for MCV as well. So low MCV is a 70+ age in years. MCV normal, it will be a normocytic anemia, and then a macrocytic anemia, which is the high MCV. The one thing I didn't put on this, because we're not talking about anemia, is that patients with low MCVs should also be considered for iron deficiency, even if they have a normal hemoglobin, because those patients may have some evidence of iron deficiency, and the hemoglobin is usually the last of the things to fall. So I would say anyone who has a low MCV should at least get iron studies if they do not have anemia per se. So what would we like you to do before the patient gets to us? So dietary history. As we all know, taking care of kids, 3-year-olds are not usually the best eaters in the world. Milk, for 2 reasons. One is there's basically no iron in milk, and second, it causes an irritation of the gut, so you get some very small blood loss over time that can be significant. We want to know if there's meat and green vegetables and those types of things. Iron studies. So for me, that would be a total iron binding capacity, iron, and a ferritin level. The reticulocyte count, because that could really help us determine where else to go. So detailed family histories. Most of the teenagers that I see with significant iron deficiency anemia, I'm very likely to think that they have inflammatory bowel disease. The patient's family history of hemoglobinopathies, menstrual histories, though I will say everyone blames the menstrual cycle for a lot of different things in life. In terms of anemia, I would say that I've seen it happen, but it's not all that common to really drop your hemoglobin below 9 in a teenage girl. And the lead levels. Again, lead is often seen in conjunction with iron deficiency because it leads to increased likelihood of pica. So what are some of the diagnoses? Again, everyone knows some of these, iron deficiency, and then we have some guidelines on how to manage that. Thalassemia, you'll see normal iron studies. You'll have a normal RDW, and that MCV to RDW is less than 13, that Metzner index. For iron deficiency, you usually see a very high RDW. And let me explain sort of my understanding of why. So cells that come out of the bone marrow are large, and that leads to a big distribution of the size of the red cells. So as soon as someone gets any iron, they're able to make a red cell. Whereas thalassemia, when you don't, because it's a genetic problem, you don't have any change of capacity of the ability to make a red cell. So it doesn't matter how much iron you get. So they all look very similar. Lead poisoning and then chronic disease is something else you might see in low MCV anemias, and often those will be associated with very high ferritins as an acute phase reactant. To segue a little bit, again, because this is by far the most common reason for anemia, is iron deficiency. Again, most childhood, especially in younger kids, is poor diet. And then in adolescence, it's a combination of poor diet and maybe menstrual cycle. But we've talked about inflammatory bowel disease already. Treatment, I recommend 6 milligrams per kilogram, but the guidelines are more, the literature is more about 4 to 6 milligrams per kilogram. And then I divide BID. There's lots of different formulations, and so I didn't put specifically the one that, you know, is the most likely to be used. We tend to use ferrous sulfate to start with. It's the most widely available. In terms of patients who need iron, IV iron, those are incredibly rare, and we'll talk about that a little bit more when we get to response to treatment. Again, ideally it should be taken with foods rich in vitamin C, spinach and fiber foods, and tea and coffee, which is not usually much of an issue in the little kids, reduces absorption. And I would also limit the milk to 16 to 24 ounces a day. When do you see some response? You should start to see a retic response within 5 to 10 days. Hemoglobin should rise about 1 milligram per deciliter per week after about 2 weeks. And then anemia should resolve sort of in the 6 to, say, 10-week range. And again, if you are seeing a steady rise in the hemoglobin, even if the anemia hasn't completely resolved, that's probably fine. And then I would continue iron for 6 months to replete any iron stores that may now be deficient. Any questions at this point as I go on to normocytic anemia? Anyone? All right. So normal MCV anemia, again, we would like to try to get a reticulocyte count. It helps us to understand what's going on in the bone marrow. What are the chronic illnesses or anything else that's affected on the CBC? Patients who have normocytic anemias may have other problems lead to sort of chronic hemolysis like hereditary spherocytosis. So bilirubin is often very useful in that situation. Again, history of hemolysis, G6PD, gallstones, any recent viral illnesses, things like, you know, parvo, those can all lead to a normocytic MCV. What do you see? So some of the obvious, acute hemolysis. So that often leads to an increase in the bilirubin. It's something that is an emergency in my mind. Acute blood loss, it should be obvious, especially if you're dropping your hemoglobin that much. And then some of the intrinsic other problems, sort of hereditary spherocytosis and sickle cell, and then chronic disease, really shutting down your marrow in putting the body's energy into trying to take care of the disease first. Treatment, again, most of these are coming back to me, but unless they're very, very mild. I would caution to try to really not miss any of the hemolytic anemias of some of the sickest patients I've taken care of. Again, they may, when I say may likely to be seen, that's by the specialists. You know, if the kid's doing well and they have a very mild anemia, I might just repeat everything in a couple of weeks and see if things are better, especially if they're hemodynamically stable. Any questions on a normal MCV anemia? The high MCV anemias is something that we see a little bit more commonly here than potentially some other areas of the country, though I imagine goat's milk is more of an issue in a lot of places. So again, reticulocyte count, and again, a dietary history, especially for goat's milk. So a folate level, and this is a blood folate level and a vitamin B12 level. So there are very few things that truly lead to a high MCV anemia. The one other thing that you might see it is in sort of a recovery issue. So someone who had G6PD or some other hemolytic process and now is recovering because the red cells as they come out of the marrow are all large. And, but the folate and B12 are very rare in pediatrics, but some things that we should consider, certainly much more common in the adult world. Things to be careful with folate and B12, they're both, so certainly B12 is very hard to get if you have a strict vegetarian diet. So bone marrow issues, you can have myelodysplasia, severe aplastic anemia, and some congenital anemias. And so those are definitely things that we would need to see in our clinic. And so for treatment, I would give both folate and B12. It's probably less of an issue for us with B12, but certainly in the adult world, you can mask some of the symptoms and you can get neurological damage if you don't give the B12 as well. And some of the diagnosis, again, goat's milk, and for those who don't remember, that's, I think, comes up in half the boards, the pediatric boards, as a question on a regular basis. Other things, tapeworms can actually cause a B12 deficiency as well. In the 10 years I've been attending, I've not seen anyone with intrinsic factor deficiency, so it's incredibly rare. And again, unless there's truly clear nutritional issues, patients should be seen by us for pretty much most of these diagnoses, unless it's a very mild anemia and you think that it, and I'm a firm believer in, a lot of these things, if patients are hemodynamically stable, maybe rechecking again in a week or two. If they have myelodysplasia or some of the congenital anemias or severe aplastic anemia, unless it's very, very severe with the degree of hemoglobin down, they could probably be rechecked in a week or two, and if it's a recovery, their hemoglobin will be recovering as well. So again, this is the guidelines. They come out much better on the vertical page than on the PowerPoint presentation. And then this is what we put together for the treatment recommendations, at least starting for iron deficiency anemia. Any questions?
Yeah, I have a
Yeah.
Wait, do you, in your experience, recommend that we as pediatricians screen all children at age 1, check an H&H at age 1? I know some people do this, some people don't.
I think the recommendations from the AAP have probably changed. I think when I did residency, it was a recommendation to do it. It's moved away from doing that. I think if there's any question with the dietary history or anything like that, then I would probably do it. But I don't think it's necessarily to be done routine. Okay.
And if we have concerns about anemia in a patient, I think there's a real gamut of what people will initially order, whether it's H&H, CBC, do they add ferritin, iron, et cetera. What would you recommend if we're seeing a patient and we have a concern about anemia? What would you say would be our start labs?
So ideally we'd go through in a progression. However, we know that getting blood from children, especially the little children, is not always the easiest. So I would say that I would want a CBC, because I would like to know what the other cell lines are doing, and with a differential, because it also gives me more information. I think if someone's clearly coming in and they're pale and they clearly anemic, they're tachycardic, they may have a flow murmur, anything that leads you to really believe that they are anemic, I would probably get a retic count at the same time. I would do the iron studies, given that it's by far the most common, and just so I don't miss it, I would probably do a bilirubin as well.
Would you routinely check these kind of labs on any of our patients who are vegetarian?
I'd have a low threshold to check the patients who are especially strict vegetarian. People who are really good about being vegetarian understand some of the difficulties of getting some of what is normally more of an animal product like vitamin B12, and they usually do something to help supplement that, especially in the children. So I don't think we need to check everyone, but I would have a low threshold.
Thank you.
Any other questions? Any cases that anyone wants to run by me or anything else?
Anyone? Can they hear us?
Anybody out there?
Can you acknowledge that you're hearing us?
They're
On the phone.
From Bowden Road, on the phone.
Hi, this is Yarmouth. We're here.
Any questions from our friends up in Yarmouth?
None come to mind.
Not immediately. because you were so thorough, Dr. SChaleff.
How about any of our friends from Bowden Road?
I don't think we have any questions here.
Okay.
Thank you.
Do you guys have any cases that you may want to just, I don't know, I figure, I don't know how much time people have, but I certainly have a little bit more time if there's an interesting case that, or it's, you know, more of a challenge that people just want to ask about. I'm more than willing to try to help with that too. Okay. So let me put it over to Mary because I can't talk about the next step. I don't know what.
Oh, I don't know what to do with this. I just want to add, as far as the sheet that Stanley showed at the beginning of the talk regarding communication with this specialty group, what we're planning to do is twofold. One, there will be a binder in each office, both for family practice as well as for pediatrics, at every location, that will include the contact sheet for that practice as well as the one-page algorithms that we'll be receiving from them as we continue to work with them. This information will also be on a shared drive on our website, Intermed's website, and we'll send out a little bit more detailed instructions of how to access that and how to possibly put that onto your mainframe. Is that what it's called, Lindsay? The main desktop, that's it, the desktop, once we have that in place. I think the only other thing we wanted to do was go through the ECW template that we had created for this. These templates are not designed to be instructions in how to manage a patient, but just to give some guidelines, information that may be beneficial when you're managing a patient with anemia. And Meg at Bowden, Dr. Meg Gralla, was going to talk about this template. Meg, are you there?
Hi, Dr. Jennings. It's Malaya. Meg is actually caught up right now with a patient.
Oh, okay. Okay.
So I'm going to double check with her right now.
That's okay. I can walk us through it.
Okay.
What I wanted to share with everyone is, are they able to see this screen?
Yep.
At the top of the screen it says PEDS in caps and then anemia. And what we're planning to do is, for all of these templates that we create for these topics, they will all start. So when you go in to search for a template in ECW, it'll start with the PEDS, all caps, and then it will list the topic. And then what we just ask is that as you take these templates and put them into your favorites, that you make them your own. So you may very well tweak it and make adjustments, and that way this main template that we're creating won't be altered. We recognized in making this template that one of the issues was that anemia is often something that we find out about in our patient population sort of after the fact. A lot of these templates will be for things like constipation, where you know in the appointment this is what you're dealing with, so this is a little bit of a different one. So what Erin Van Wegnen and Meg Gralla tried to do was just kind of be very comprehensive about it. And I don't think I need to walk you through. I think it's very straightforward. Just some of the things that we may be wanting to ask about in the HPI, and then a very basic exam, and then finally in the treatment plan, the type of anemia. Oftentimes we don't even have this much information during the appointment, but again, just as a guideline for people. Does anyone have any questions about that? I think it's all very straightforward. Okay.
All right.
Great. Thank you.
Is there anything else? Any other questions? Most of you know me by now and know our group. And again, I just want to make sure that we would gladly take 100 questions that may not be the most relevant to try to make sure we don't miss some of the important ones. So really don't want you guys to have any hesitation to call. Okay?
Thank you.
You're welcome.
So Eric, was this audio taped?
Yeah, that's what I'm doing.
That's what you're doing right now,
So,
but not videotaped?
it was not videotaped, just the audio.
And it'll be the slides.
Yep.
The slides and the audio will go together.
Right.
Beautiful.
So,